Before we start the session, I just want you to know this quote. That is, start by doing what's necessary, then do what's possible, and suddenly you are doing the impossible. So it means whenever you feel that your time is hard now, just keep going. One day you will be seeing yourself on the other end where you're always you wanted to be. So our topic of discussion today is interpretation of urodynamic graphs. Before we go into the actual topic, let us discuss some basic concepts. So urodynamics. What is urodynamics? It is the measurement of the relevant physiological parameters of the lower urinary tract to assess its function and dysfunction. So the lower urinary tract includes the bladder and the urethra. So what is uro? Uro means urine and dynamics means a continuous activity. So remember, urodynamics is a continuing test and it is not just a single picture. So we have to know the normal physiology that is happening in the bladder. So the function of the bladder, as we all know, it is to fill the urine and void the urine, right? So what is happening during filling? There is sympathetic activation, right? So there is sympathetic activation, detrusor muscle relaxation, and urethral smooth muscle contraction during filling. Whereas during voiding, what is happening? There is parasympathetic activation, detrusor muscle contraction, and urethral muscle relaxation, right? So this we can understand it better by using this diagrammatic representation. So first, what is happening? There is bladder filling. So the detrusor muscle is relaxed here to collect the urine, and the urethral sphincter seems to be contracted here so that it doesn't allow any leakage of urine during bladder filling, right? And then when the bladder is half full, the patient will feel the first sensation to void, okay? And this time, the urination can be voluntarily inhibited until the appropriate time will come for the patient, right? And then almost when the bladder is full, see here the bladder is almost full. So this is when the patient have a normal desire to void and then she will go for maturation. So during this time what happens? The detrusor muscle will be contracting from all the walls of the bladder, and finally the urethral sphincter also relaxes to allow the collected urine to go outside. So this is when we see the actual leak. Okay, so this is normal physiology we have to know, right? Now, this concept is also very important to understand urodynamics as such, but this is also a normal physiology that is happening. See, in conditions which will increase the abdominal pressure, say when we cough or we perform a Valsalva maneuver, there is increase in abdominal pressure. And definitely, this abdominal pressure will be transmitted to the bladder and this will be reflected upon the bladder cavity, right? And also remember, in certain cases, when the detrusor muscle is contracting, like when the detrusor muscle is attempting to contract to void the urine, this detrusor pressure will also be transmitted to the bladder cavity, right? So the whole bladder pressure, when both these are acting on the bladder cavity, it can be given as P vesicle is equal to P abdomen plus P detrusor, right? Yes. Coming to the next one. So I just want you to talk upon the important terms we use in urodynamics. Now, these three components, that is stress urinary incontinence and urgency incontinence and mixed incontinence, are the terms we use when we see the patient clinically, right? So stress urinary incontinence means when the patient is complaining of involuntary leakage of urine. Okay, see, there is involuntary leakage of urine on effort or exertion or on sneezing or coughing, right? Then comes urgency incontinence. So here the patient complains of involuntary leakage that will be accompanied by or immediately preceded by urgency. So what is urgency? There is a sudden and compelling desire to pass urine, and that will be difficult to differ for the patient, right? Next comes mixed incontinence. So simple, the two combinations will be seen here. Okay, the combination of stress urinary incontinence and urgency incontinence will be seen here. So here there will be urgency also and there will be leak that will be seen with effort, exertion, sneezing, or coughing also, right? Okay. Now, the actual clinical terms we are not using in urodynamics. We use specific terms like urodynamic stress incontinence and detrusor overactivity, right? So first, let us see what is urodynamic stress incontinence. So urodynamic stress incontinence, okay, it is noted during actually the filling cycle or when we perform cystometry in urodynamics, okay, that is filling cystometry in urodynamics, and it is defined as involuntary leakage of urine that is during increased abdominal pressure. But remember, this is very important. There shouldn't be any detrusor contraction, right? Now, let us understand what is overactive bladder first. So, overactive bladder means the symptom complex of urgency that can be with or without urge incontinence. Incontinence means it should be associated with a leak. Okay, so overactive bladder is the symptom complex of urgency. There is urgency, but it can be associated with urge incontinence or it can be without urge incontinence also. Okay, so that thing you have to understand. And that can be associated with frequency of nocturia also. But remember, this occur in the absence of urinary tract infection or any other obvious cause. Understood? Yes. So this is overactive bladder. So now why this overactive bladder is happening? So it occurs due to the involuntary contractions of the detrusor. Okay, so that is happening during the filling phase of the micturition cycle. Understood? So finally, what is the term you are using in urodynamics is this one. Okay, so that is detrusor overactivity. So it is defined as a urodynamic observation that is characterized by involuntary detrusor contractions, and especially this is seen during the filling phase that can be spontaneous or it can be provoked also. Okay, spontaneous means it is spontaneously happening during the filling phase, and provoked means when we ask the patient to do coughing or to do Valsalva maneuver like that. Okay, so during these provocative actions, there is detrusor muscle overactivity. I hope you have understood. Yes. Now, as we have seen, detrusor overactivity is a urodynamic diagnosis, right? Now, when we give a final diagnosis, we can also term it as wet overactive bladder or dry overactive bladder. As we know, overactive bladder is something that is happening due to detrusor overactivity. So, wet overactive bladder means there is detrusor overactivity which is associated with leak, and dry overactive bladder means there is detrusor overactivity alone and there is no incontinence. As we have seen previously, there is no incontinence or there is no leak. Can you understand? Yes. Now, let us see what are the indications of doing urodynamics. So, indications of doing urodynamics or when there is a clinical suspicion of detrusor overactivity and when there is a previous surgery of stress incontinence or anterior compartment prolapse has been done, there are symptoms of voiding dysfunction before any complex reconstructive or urological procedure, and when the initial treatment has failed in treating incontinence. Okay, so these are the important indications of doing urodynamics. And prior to during urodynamics, what will we do? We should obtain the history. We should ask for the symptoms of the patient, and we should also know about the past medical history of the patient, what kind of medical treatment the patient has taken. And finally, we have to check for the physical examination also in the patient. We have to do a neurological examination as well, and also a pelvic and abdominal examination. Okay. And during pelvic examination, we have to look for these three parameters, that is whether the patient has a prolapse or there is a pelvic mass or whether there is genital atrophy like that. Okay. And also we have to do urine dipstick before the procedure to check whether the patient has any hematuria or infection. Even then, this procedure is an invasive one. That is, some steps of invasive methods are also included. But even then, there is no need for prophylactic antibiotics. Okay. And also, if the patient is on antimuscarinic already, it depends upon the clinician's decision to whether or not stop any medications. right? So this is multi-channel urodynamic test components. So we will have uroflowmetry, cystometry, pressure flow study, urethral pressure profile, and electromyography. Okay, so these are the 5 components: uroflowmetry, cystometry, pressure flow study, urethral pressure profile, and electromyography. Now I'm just going to explain about all these 5 components. Even then, we are not going to deal in detail with everything. Okay, so first, what is uroflowmetry? Uroflowmetry is a non-invasive procedure. Okay, so here we'll be doing assessment of the free flow of the urine voided per unit time, and it will be measured in milliliters per second. Okay, and it will be performed in patient's preferred position. The patient will be voiding while sitting on a commode over a rotating disflowmeter. Okay, so this is a commode where the patient will be sitting and voiding, right? And remember, during this procedure, the patient's dignity and privacy should be maintained. Next comes the cystometry. So cystometry is an invasive procedure as opposed to uroflowmetry, which we have seen it as a non-invasive procedure. In uroflowmetry, we are just asking the patient to void and just recording how the urine is flowing, how much the patient has voided, like that, right? But cystometry means we are going to attempt to we are attempting to learn about the bladder by doing some interventions. Okay, so it is an invasive procedure. So here we are inserting a single or a double lumen catheter, and as we've already seen, we have to know about 2 important parameters here, right? One is the pressure abdomen and the other one is the pressure vesicle. Okay, so this pressure abdomen can be measured by inserting the catheter into the rectum, vagina, or the intestinal stoma, and the pressure vesicle, that is the bladder pressure, can be measured by inserting the catheter via the urethra, or if it is not possible, then you can insert the urethra through the suprapubic space also. So this cystometry provides information regarding bladder sensations and also the reaction of the detrusor muscle to this filling. Cystometry usually ends with a micturition command. Yes, when the bladder is filled, finally we'll be asking the patient to micturate, or we'll be giving a permission to void, right? Next is pressure flow study. So what is pressure flow study? During this pressure flow study only, we'll be measuring the pressure of the detrusor muscle. Okay, so just after the patient has been given a command to void, this pressure flow study will be started. So during this time, we can know if there is any poor flow of the urine. Okay, so if there is any poor flow of the urine, it means that there is impaired detrusor contractility or bladder outlet obstruction. And after finishing this pressure flow study, we'll be measuring the post-voidal residual urine. Okay, yes. And finally, we'll be doing urethral pressure profile also and electromyography, which is also included in this urodynamics. We are not going to discuss it in detail, but just know that urethral pressure profile means the bladder catheter will be slowly removed and the pressure at various points on the urethra will be measured. And electromyography means electric potential to study the perineal muscle activity using surface electrodes will be done. Right? Now, so this graph now is the diagrammatic representation of the uroflowmetry we have seen. So what we have done in uroflowmetry, the patient has been sitting in a commode and she has voided. Okay, so now how the flow of the urine went. Okay, and what was the maximum time taken for the patient? How much volume was voided by the patient? All these things will be represented in this graph. Okay, so if you see in the x-axis we have the flow time and in the y-axis we have the volume voided. So here also the 2 useful parameters we use is the maximum flow rate. So when is the maximum flow rate has been achieved by the patient? Okay, so the time to achieve the maximum flow will be checked. And another important parameter is this area under the curve, that is the voided volume. Okay, so this voided volume and the maximum flow rate. Okay, so these are the 2 important parameters we'll be checking out here. Okay, right. So usually the shape of the flow curve should also be assessed. Normally, this curve will be bell-shaped, which will be having a rapid upstroke, and the curve will be with a continuous flow and will be having a Qmax. Okay, Qmax means the point at which the maximum flow rate has been obtained, and after attaining a Qmax, it will be slowly declining and it will be ending. Okay, just as we see here. Okay, so first it will be starting, it will be reaching a maximum rate, that is Qmax, and finally it will be coming down and ending like this. Okay, you will normally get a bell-shaped curve like this in uroflowmetry. Okay, so what is the normal Qmax in females? Okay, it is 20 to 36 milliliter per second. So this is the normal Qmax that will be reached in the female. Suppose whenever there is low Qmax, okay, it can be due to low voided volume. When the volume is less than 150 milliliters, then you will have a low Qmax. See, important thing is this voided volume, okay, because it determines how how distended the bladder fibers are, and also it determines the maximum flow rate as well. So whenever there is a low voided volume, less than 150 ml, usually this test will be repeated, right? And this low Qmax can also be seen when there is overfilling of the bladder, that is more than 550 milliliters, when the patient is incubated to void, or when there is calibration or recording problems with the machine. Okay, and sometimes there can be overestimation of the Qmax also. So this can occur due to the artifacts. Okay, because when the patient is sitting over the commode and voiding, the stream can be wandering on the spinning disc of the Uroflowmeter, and this can cause some artifacts, and that can cause overestimation of Qmax. Clear? So that is the thing about this, right? Now we'll see some important abnormal flow patterns that can be seen in uroflowmetry. So first one occurs due to obstruction. So this is one abnormal flow we get. Okay, what's happening here? There is an abnormal plateau-shaped graph that is having a prolonged flow, and if you see, there is a decreased Qmax also. So normally we saw the Qmax is going to be from 20 to 36 milliliter per second. But what is happening here? The Qmax is only 7 milliliter per second, and you see the flow is also not a proper bell-shaped curve, and also it is prolonged and the Qmax is finally decreased, right? So whenever you see this should make you think about any obstruction that is happening. That is, it can be due to urethral kinking that can be occurring with the cystocene, or it can be due to a hypercontractile bladder when there is a low pressure, and also this obstruction can have another type of presentation also. Okay, so this is also due to obstruction where you're seeing intermittent flow. Okay, so the flow is intermittent here. Okay, the urine stream starts, stops. Okay, it will be intermittent. Okay, so this pattern of flow can also be seen in obstruction or a hypercontractile bladder. So remember, in obstruction we can have these two types of abnormal flow patterns. Clear? Right. Now, this is another pattern. So when the patient is attempting to void by performing repeated Valsalva maneuvers and straining, this can lead to fluctuating and intermittent flow. Okay, so that will be represented by several peaks in the Qmax. Okay, so you see several peaks are there in the Qmax like this. Again, the patient is trying all these maneuvers because there is again a bladder outlet obstruction, or there is unsustained dead result contraction. Right? Okay. Coming to the next abnormal pattern in uroflowmetry, here we are definitely able to see this is not a normal bell-shaped curve. What is happening here is, here we are getting a plateau shape again with a reduced Qmax. In other words, we can tell it as a box-shaped curve. Okay, so this is usually, see, whenever you see this box-shaped curve, you have to think about urethral stricture. Okay, or there is external urethral compression and the bladder flow outflow obstruction that can be happening due to prolapse or following incontinence surgery like that. So urethral stricture is one important cause for this type of pattern that is seen in uroflowmetry. Okay. Next pattern is very high Qmax. Very high Qmax means there is a rapid upstroke and rapid downstroke. And the cause of this pattern in uroflowmetry is dead result overactivity. So the patient is performing high-speed squirting action to overcome an obstruction. So this is also to overcome an obstruction again. Clear? So these are the various patterns of uroflowmetry you have to know. So as we have already seen, after uroflowmetry, what we will do? We will check for the post-void residual urine, right? So we have to record the post-void residual volume to evaluate the extent of bladder emptying. So how much the patient has emptied now. And the remaining intravesical fluid volume after complete emptying will be measured now. Now, we can measure it either sonographically or with a catheter. Obviously, ultrasonogram is preferred over catheter because ultrasonogram is non-invasive. And when you perform an invasive procedure like catheter, we may introduce infection. Okay, fine. Now, this post-void residual urine is normally less than 50 milliliters, or it is 10% of the total bladder volume. Whenever the patient is asymptomatic, we can also take it up to 100 ml. So a less than 100 ml is also not recorded as that much clinically significant if the patient is asymptomatic, right? But when there is more than 150 ml of post-void residual urine, then it is considered abnormal because it can occur in detrusor underactivity when the patient is on anticholinergics or when the patient is having bladder outlet obstruction, right? Okay. Now, let us see in detail about cystometry. So what's happening in cystometry actually? So there is artificial filling of the bladder we do in cystometry. So first we performed uroflowmetry. The patient has voided whatever urine has been collected naturally. Now to perform cystometry, we have to fill the bladder artificially. Understood? So what we are going to do, we have to continuously fill the bladder with fluid that will be introduced through a catheter. Okay. So usually we'll use a thin transurethral catheter that is used for bladder filling and pressure recording. Okay, so we will have a double lumen catheter here. One lumen will be used for bladder filling and the other lumen will be connected to the pressure flow meter, right? And the initial resting pressures of the vesicle and the abdomen should be recorded at the beginning itself. And what we'll be using to fill the bladder? We'll be using normal saline at room temperature and it will be filled at a rate of 1 to 2 milliliter per minute, right? So this is how we do. Okay. So here, what you're able to see that the first catheter, which is a double lumen catheter, is inserted into the bladder, right? One is used to filling the catheter. See, the fluid is going inside the bladder via this catheter, and the other lumen from the catheter is connected to the pressure transducer to record the bladder pressure, right? And you see another catheter over here that is inserted into the rectum. Usually, we prefer rectum over vagina because the rectum has external urethral sphincter. It can hold the catheter when we insert it. Okay, so this is connected to the pressure transducer, and whatever the pressure is made during filling, okay, even during filling, whatever the pressure is made by this abdomen, vesicle, and the detrusor muscle, okay, it will be recorded onto the graph. Now we have directly inserted catheters into the vesicle to measure the bladder pressure and a catheter into the rectum to measure the abdomen pressure, right? Now let us see how we'll be able to get this detrusor pressure. So I'll come to this later. Before that, let us see this concept, okay? So normally during filling phase, that is when the bladder is at rest, what is going to happen? The abdomen pressure and the bladder pressure are going to remain the same, right? So the bladder pressure is 10, the abdomen pressure is also 10. Remember, the detrusor is not going to, okay? Next comes the provocation measures we give to the patient. Suppose when the patient is coughing, what is going to happen? There is increase in the abdomen pressure. This will be transmitted to the bladder. Okay, so there is increase in pressure to 85 and this is transmitted to the bladder to 85, but this is not reflected on the detrusor. See, the detrusor line is flat, right? Now, what happens during voiding? There will not be any increase in abdomen pressure. Abdomen is not going to act over here, right? But what happens? The detrusor will be trying to push the urine outside. So this pressure will increase and also the bladder pressure will also increase. Okay, so this is the very basic concepts and this is all about urodynamics, what we are going to learn. Okay, so while performing this procedure, we have to ask the patient about the perceived sensations during the filling also. Okay, so first, when the patient got first sensation of filling, the patient feels when the bladder is no longer empty. Then comes the first desire to void, when the patient wants to void actually without any hurry. Next comes the strong desire to void. That is, this strong desire to void means the patient is having equal maximum that is equal to the maximum cystometric capacity, and at this point the patient will not postpone voiding at all. Next comes a feeling of urgency, fear of leaking or pain or any other symptoms. Whatever the patient tells, we can record it over the cystometrogram, right? So as I've already told, during filling the patient will be asked to cough every minute, so to assess the recording quality. And also during this time, you have to understand the point that as we have already seen during coughing, the pressure in the abdomen and P vesicle will rise, right? And also the patient will be asked to do some provocative measures like listening to running water or washing hands. So this will elicit the patient's symptoms are performed, and these provocative measures will also be performed throughout the test. So any leakage during coughing or provocative measures are annotated on the cystogram, right? So what are the important points we have to keep in mind? With normal detrusor function, there will be no change in the P detrusor throughout the filling despite provocation. Okay, despite provocation, the P detrusor will not show any change. This is the important point we have to keep in mind. So these are some important values of urodynamics. We have the bladder capacity, that is 400 to 600 ml. The first sensation will be coming at 150 to 250 ml, and the detrusor pressure during filling will be less than 15 centimeters. During voiding will be less than 70 centimeters. The peak flow rate will be more than 15 milliliter per second. The flow time taken will be 15 to 30 seconds. The Qmax reached at 25 milliliter per second, and usually the residual volume will be less than 50 milliliters. Okay. So as I've already told, so this is the formula, right? What we have seen from the starting. So the vesicular pressure will be determined by the detrusor pressure as well as the abdominal pressure. But we know we'll be measuring the abdominal pressure and the vesicular pressure by inserting the catheters, right? But how we measure the detrusor pressure is arriving with this formula. Okay, so we'll have to separate the abdominal pressure from the vesicular pressure to get the detrusor pressure. Okay, so normally the P vesicle is 5 to 50 centimeters of water, and pressure abdomen is 5 to 50 centimeters, and pressure detrusor normal value is between 5 to 15 milliliters, right? Next comes the detrusor pressure. So as we have already seen, so the detrusor pressure during filling should be less than 15 centimeters, and during voiding should be less than 70 centimeters, right? So what is happening here? There can be two conditions that can happen when there is no detrusor pressure is not proper. Okay, so in hypertonic bladder, what is happening? The detrusor pressure is low, and in bladder outlet obstruction, the detrusor pressure is high. But in both the things, the flow rate will be low. Okay, so how we can differentiate between these two? We can differentiate it by measuring the urethral pressure. So urethral pressure will be normal in a hypertonic bladder, and it will be high in the bladder outlet obstruction. Clear? So in bladder outlet obstruction, when the bladder is trying to overcome the obstruction and void the urine, the detrusor pressure and urethral pressure both will increase. Whereas in hypertonic bladder, the detrusor pressure will be low because the tone of the bladder itself is low. But it is trying to overcome the pressure, so the urethral pressure will be normal. Okay? Yes. Now, this urethral pressure is used to differentiate. I just added this point to know about the stress urinary incontinence. We are not as such using this in urodynamic graph interpretation. So this is used to differentiate stress urinary incontinence. That is, it can occur due to intrinsic sphincter defect or hypermobility of the urethra. So here the urethral pressure is usually less than 25 millimeter, means then it can be due to intrinsic sphincter defect. Suppose if it is high, that is more than 25 millimeters, means it can be due to urethral hypermobility. Right? Okay. Now coming to our actual picture, the interpretation of urodynamic graphs. So first, let me take you to the normal urodynamic study. Okay. So remember, there is no specific color destined in the graphs, or there is no specific there is no specific order in which all these pressures are annotated on the graph. Okay, so whenever a graph is given to you, what you have to do is you have to check for the P vesicle, P abdomen, and P tit where it is written, and whatever they have mentioned in the graph, you have to look into it. Okay, so if they are mentioning cough, the first sensation, the capacity, urine flow peak, okay, then that is whatever the pressure they have mentioned, you have to look into this. And so yeah, so what is happening here? The patient is asked to cough. So when the patient is coughing, what is happening? There is increase in P vesicle and P abdomen. So normally will come like the normal physiology itself. Like when the patient is coughing, the pressure abdomen rises and the P vesicle also rises. But the P detrusor is not acting here. See, there is no increase in the pressure, right? Also, whenever there is a leak, they will mention it here somewhere like leaking, or they will represent it by a pictorial representation at least. But that is also not seen here. That means there is no leak during coughing, right? So that means there is no stress urinary incontinence, and over this area, which is the filling phase. Okay, so till this to this is the filling phase. During this phase, there is no action in the detrusor also. Okay, there is no peak in the detrusor contraction. That means there is no activity in the detrusor muscle. That means there is no detrusor overactivity also. And finally, we are not able to see any leak mentioned over here. Okay, so this is the flow pattern. What we are seeing here is the flow pattern where you are able to see a normal bell-shaped curve. Yes, so this is when the patient is osteovoid. So here also you get a normal bell-shaped curve. So that means this whole study is normal, right? Now let me take you to some abnormal graphs, but I have given much simpler representations over here. So we are able to see the pressure vesicle, P abdomen, and P detrusor, and C means cough. The patient is also cough over here. Okay, so when the patient is coughing, what's happening here? The pressure in the vesicle and the pressure in the abdomen are increasing. Okay, so normally there shouldn't be any leak, right? But what is happening here? There is leak. Okay, so this is what leak. In the flow rate, they have mentioned this is leak that is happening. So this means this is a urodynamic stress incontinence. Okay, so when the patient is coughing, there is a leak and there is increase in pressure. Okay, but there is no rise in P det. Okay, so this also you have to understand. Okay, so this is a graphical representation of urodynamic stress incontinence. So let us see this graph. Okay, so this is where the patient is given on filling cystometry. Okay, so this is the volume infused over here. We are able to see the vesical pressure that is increased, and that here the detrusor pressure is increased, right? But the abdomen is not increased, and they haven't given any provocative measures or cough also. That is not represented in the graph, right? So during this time, what has happened when whenever the detrusor pressure is increasing, there is a leak. Okay, so that means this patient is having a detrusor overactivity with leak. That means we can also tell the patient is having a wet overactive bladder, right? Yes. Now, let us interpret this graph. So in this graph, what you're able to see. So this is a whole graph, right? So first, we have to check for the pressures. Okay, where is so this is the subtractor pressure, that is the P detrusor pressure, and this is the bladder pressure, and this is the abdominal pressure. Okay, so first the patient is also perform provocative maneuvers. Okay, so this is the entire filling phase. Okay, so this is the filling phase and this is the voiding phase, right? So during this filling phase, the patient is given provocative measures like coughing and Valsalva. But in the starting, we are not seeing any leak. Leak is not visualized. Okay. But as the filling is increasing, what is happening? Yeah, we are able to see a detrusor overactivity here, right? A detrusor overactivity here that is representing in the bladder pressure also, and that is also coming with the leak. Okay. And slowly, when the patient is coughing itself, okay. So again, the patient is coughing, and this time, what is happening? During coughing itself, the pressure increases in the bladder and we are able to see a leak over here. Okay, so this means the patient is having detrusor overactivity as well as detrusor urodynamic stress incontinence. That means this patient is a case of mixed urinary incontinence, right? So this is the filling pressure and voiding pressure. You are able to see leak with detrusor overactivity and leak with cough also. So this is a mixed urinary incontinence. Okay, so this graph we have to, so far we have seen whatever happened in the filling phase, right? Now here we are going to see what's happening with the voiding phase. So this is the overall filling phase. Okay, so in the filling phase, we don't see any abnormality. The filling phase is acting normal. But when the patient is osteovoid, there is sudden increase in pressure in the detrusor and vesicle, which normally happens. But if you see the flow pattern over here, this is not normal, right? So how is the flow pattern? As we have seen the Uroflowmetry, this flow pattern is somewhat plateau shaped, right? So this is not the normal bell shaped. So what is the possible diagnosis here? So this is bladder outlet obstruction. Okay. So as we have seen here, the P detrusor and P vesicle pressures. So this is, yes, it is very high, right? It is very high. And when you see the Uroflowmetry, you're having a low Qmax, okay, and the flow rate is also not that high. That means bladder outlet obstruction. So remember, in bladder outlet obstruction, we'll be having a low flow, but we'll be having very high pressures. Okay, right. Now, this point I want, this graph I have put intentionally because I want you to understand that you have to see a significant rise like this. Okay, so whatever you see here, these are small oscillations, okay, that is happening during the phase. And these are artifacts that are caused by the pump vibrations. Okay, so you need not worry about this. What we generally do is you have to look on where is the vesicle pressure, in which line it is represented, the pressure of the abdomen, the pressure of the detrusor that you have to find. And in some graphs, they will be giving a detailed representation of whatever they have done. CG means here cough, FT means it is the first desire to void, and ST means it is a strong desire to void. Okay, so like that. Okay, and here the patient started voiding. So that means till this, it is the filling phase. And after this, the patient has started voiding. Okay, here they represented it as a voiding phase. Now, what is going to happen during the filling phase? What we see here, there is activity in the detrusor. Yes, so this is a significant one. Okay, so this is a significant one, not the small oscillations. Okay, so this is a significant one, and this one is also represented in the same pressure has been seen in the P vesicle also, but nowhere we see a leak. Okay, so the leak is not mentioned anywhere. So we can take it as detrusor overactivity alone. That is detrusor overactivity without leak. That means it is a dry overactive bladder. Okay, I hope this is all about the urodynamic graphs. We have seen the most important types of graphs that will be asked in the exam, right? So finally, wishing you a success in your exams. May good luck be in your favor and your preparation bring fantastic outcomes. Signing off, this is Dr. Agalya Kulandevelu, mentor from StudyMEDIC RRR Series. Thank you for your participation.